Okay, duodenal atresia. Duodenal atresia is a failure to recanalize the duodenum. This is associated with Down syndrome. You can remember the D in duodenal atresia for the D in Down syndrome. So what happens here is that early on, our epithelium is proliferating all over the place. It's not like you keep an open lumen throughout your entire GI development. It actually grows into that region temporarily, and your body is able to eventually take out the cells that it doesn't need and create a healthy lumen. In duodenal atresia, however, you have this epithelial proliferation into the lumen, and your body forgets to remove it. And what happens over time is that epithelialization will create its own dead ends, basically. And so you have this connection and nothing recanalized. And so that's how you get duodenal atresia. And so this will present very quickly in life because you don't have a GI tract that functions well. In the first 48 hours of life, you're going to have either bilious or non-bilious vomiting. So let's talk about what that means. Bilious vomiting is yellow-green vomit, and you'll see that in the presence of bile. And you only see this in conditions where your oral cavity and all the way through the second portion of your duodenum are clear, where you have a connection between those. So if you imagine, and that the only reason that would be the case is because all of our bile is coming from our gallbladder into the second portion of our duodenum. So let's say, for example, that you had this duodenal atresia located distal to this region, you would see bilious vomiting because this bile can come back proximally and you can throw it up. But if in duodenal atresia, if it happens proximal to where the common bile duct empties into your duodenum, you would have non-bilious vomiting. So you can present with either in this case. You'll see abdominal distension oftentimes, but what they really love to test you on and what you have to know is that on X-ray you're going to see what's known as the double bubble sign. And this is a dilated stomach and proximal duodenum. So here's an X-ray of somebody with duodenal atresia. You can see here that one of the bubbles is the stomach, and the second bubble is located here. That's our proximal duodenum. And I'll show you what that looks like. Let's imagine you have duodenal atresia right here. Our first bubble is our stomach. Our second bubble will be this duodenum. And the reason there are two bubbles is because remember, we still have this pyloric sphincter right here that can close and create two distinct gas-filled cavities. You have to treat this surgically in order to fix it. And let's talk about the other types of atresia, jejunal and ileal atresia. These actually arise from a totally different mechanism than duodenal atresia. They arise from disrupted vascular supply. That can lead to necrosis, and then you'll get bowel resorption. So this can happen to anybody, really. If in utero, there's a lot of stuff going on, and so sometimes you might have a vascular event. Let's say you have a vascular event that affects this portion of your bowel. What's going to happen is that this portion of your bowel will die, and these two ends will resorb and form two different ends. So now you have atresia. Again, this will present very early on. This will always present with bilious vomiting, though, because as we just saw, the bile can easily reach the duodenum and exit to the oral cavity in the event of vomiting because all the bleeding in jejunal and ileal atresia happened much more distal to this section. Again, you'll see abdominal distension. A good way to differentiate this from duodenal atresia is that you'll see a triple bubble sign. And remember that both jejunal and ileal atresia, because they're happening spontaneously after vascular events, they're not associated with things like Down syndrome. So here's a triple bubble sign. You can see the stomach, here's the duodenum, and then there's the jejunum. So you get three different bubbles appearing. And again, this has to be treated surgically. We're almost done. Let's talk about malrotation and midgut volvulus. So malrotation, as the name suggests, is abnormal rotation in utero, specifically of the midgut, and you'll end up with improper bowel positioning. So what happens here if we have our embryologic midgut? Normally, our liver is going to push and cause this physiologic herniation. While it's herniated, you're going to have 90 degrees of rotation. Then your bowel is going to get pushed back into the normal abdominal cavity, and you'll have another 180 degrees of rotation. They do want you to know that there's a total of 270 degrees counterclockwise rotation during our development. And any defect in this process can lead to malrotation. Here's probably a better picture showing the malrotation. You can notice here we have our 90 degrees. This shows the rotation happening prior to herniation. I've seen it both ways where you can herniate first and then you have your 90 degrees. And then what happens is that the bowel will return and then you'll have another 180 degrees post herniation. And notice that's how we form our cecum right here in the right lower quadrant. And then we have our intestines and we have our, ascending, transverse, descending colon. You could already see it forming after this herniation. And there's the 90 and then there's the 180 that we talked about. So a complication of malrotation that you have to consider is duodenal obstruction and volvulus. The reason this happens is that we have something called Ladd bands. So Ladd bands normally attach our cecum to the right lower quadrant, but if they're in the right upper quadrant, they can start messing with different regions of your small intestine, especially your duodenum. So let's see how that works in action. So Ladd bands normally attach your cecum to your right lower quadrant. So here's our correctly rotated bowel, and we'll have a Ladd band there, and you're not going to have any problems. The thing is, in malrotation, your cecum's in the right upper quadrant, or it can be midline like it is here. And if you have a Ladd band in this region, what's going to happen is that that Ladd band can start messing with the duodenum that's located up there. I'm going to show you that the duodenum's just right there, and that can cause either duodenal obstruction or a midgut volvulus. And a midgut volvulus would be where the duodenum starts twisting on itself. So let's talk about what's going on with a midgut volvulus. There's different types of volvulus, but midgut is the one you're often going to see in young people. It's due to a congenital malrotation, and it's because of these Ladd bands allow basically our intestines are kind of this free-flowing organ, and they can't twist around each other that well because they don't have anything to grasp onto to start twisting around itself. But the problem is these Ladd bands, if a Ladd band attaches to your duodenum, now that you've created something that the duodenum can use to start twisting around its own mesentery and cause a volvulus. This will present with bilious vomiting during the first weeks of life. You'll see transient abdominal pain as it twists and untwists. You can diagnose this with an upper GI barium series. You can also see air fluid levels on an X-ray, and you have to correct this surgically. When I think about how they test this, they usually test this in the setting of you'll know somebody has a midgut volvulus, and then they ask you why this happened, and you'll have to know that there was some sort of malrotation that caused the volvulus. Or they'll tell you that somebody has malrotation, and they'll ask you what they're at risk for, and the answer would be midgut volvulus. The last two are pretty low yield, but I wanted to include it for completion's sake. Necrotizing enterocolitis. This is, as the name somewhat suggests, with the necrotizing, this is necrosis of your intestinal mucosa in newborns. You'll always see premature delivery. I've never heard of a question of somebody, or even a real case in life, where somebody who's at term will develop this. Always related to premature delivery, and formula feedings are really important risk factors. What can happen with necrotizing enterocolitis is you can have perforation because your bowel's dying. And a really important test that they like to show is they'll give you an X-ray that shows this thing called pneumatosis intestinalis, which is air within the bowel wall. And here you can see this X-ray looks nothing like anything we've seen before. And that's because you have air filling up the bowel wall in a ton of these different regions. And this is called pneumatosis intestinalis. So if you get a question, what'll happen is they'll give you a question of a baby who's born at like 30 weeks or 28 weeks, let's say, and they're getting formula fed and they have all this pain and they do an x-ray and it shows this. They want you to realize that that's necrotizing enterocolitis. The last disease I'm going to go over is hemorrhagic disease of the newborn. I mentioned this briefly when we talked about fat-soluble vitamin deficiencies, but vitamin K is normally synthesized by our intestinal bacteria. And the problem with little kids, newborns, is that they haven't developed their bacterial flora yet. So they could actually have a vitamin K deficiency. This is why that we, in the United States at least, every newborn gets a vitamin K injection to prevent them from this specific condition. So vitamin K is a cofactor for multiple clotting factors. And if you have any vitamin K deficiency, it can lead to bleeding. I showed you this earlier in the vitamin K, the fat soluble vitamin deficiency section. But here, I just want to mention that vitamin K is normally synthesized and it's a cofactor for several of these clotting factors. And I've highlighted them here. And all these clotting factors, their main job is to ultimately give you a fibrin clot. And if you have a deficiency in any of these factors, it can lead to bleeding. So this will present as somebody with significant bleeding. Often they'll present with intracranial bleeding in a patient who hasn't received any prenatal care or postnatal care mostly. You'll see on labs an elevated PT and PTT, and you'll see a normal bleeding time. I talk about this in the DIC lecture and then liver diseases as well, but it's important to know the difference between prothrombin time and partial thromboplastin time. So PT or prothrombin time, a good mnemonic to remember what pathway will elevate your PT. Remember that you play tennis outside, and so you'll get damage to the extrinsic pathway will elevate your PT, essentially because vitamin K is a cofactor for factor 7. If you have a deficiency of factor 7, that's going to affect your extrinsic pathway, and that can prolong your PT. So that's why that's elevated. PTT is elevated in this case. And I want you to remember that PTT, the mnemonic is that you play table tennis indoors. That should remind you that PTT is a measure of your intrinsic pathway. And again, you can notice that factor 9, factor 10 are affected and they're part of your intrinsic pathway. And any defect in your intrinsic pathway will elevate your PTT. And the last thing we'll talk about is your bleeding time. Your bleeding time has nothing to do with this coagulation cascade that we're seeing. Your bleeding time has everything to do with your platelets. So because your platelets are fine, there's no damage, your vitamin K is not required for platelet formation and activation. There's no damage, so you'll have normal bleeding time. You have to treat this with vitamin K, which makes sense, and you can give transfusions as needed. And like I said earlier, is that the main treatment we have is more preventative. If you give vitamin K injections to newborns, you avoid this disease altogether. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.